Councillor Bill Withers. I welcome other witnesses, Sally Baker and Hannah Clark from Surrey County Council, June Haynes from Hampshire County Council, Esther Prangley from Bracknell Forest Borough Council, and I also welcome the following attendees joining in person from Frimley Health NHS Foundation Trust, Lance McCarthy, Chief Executive, Frimley Health NHS Foundation Trust, Caroline Hutton, Senior Responsible Officer for the New Hospital Programme at Frimley Health NHS Foundation Trust, Alex White, Programme Director, Frimley Health NHS Foundation Trust, Kirk Ward, Director of Communications and Engagement, Frimley Health NHS Foundation Trust, and from NHS Frimley Integrated Care Board, Ellie Davies, Associate Director of Communications, and Sam Burrows, a Managing Director, NHS Frimley Integrated Care. And I'd also like to welcome the following joining remotely: Paul Mustoe, Joint Senior Responsible Owner for the New Hospital Programme, Andrew McCaw, Team Leader Policy for Reinforced Autoclave Aerated Concrete and Schemes, Wave 1, Programme Strategy, Funding Policy and Schemes, New Hospital Programme Sponsor Team, and Eleanor Schofield, Strategy Manager, Programme Strategy, Funding Policy and Schemes, New Hospital Programme. And thank you also to Surrey Heath Borough Council for facilitating this meeting at this venue. And in particular, thanks to Eddie Scott, Senior Democratic Services Officer, Surrey Heath Borough Council. Mobile technology and filming, acceptable use, and social media. Those attending for the purpose of reporting on the meeting may use social media or mobile devices in silent mode to send electronic message about the progress of the public parts of the meeting. Anyone is permitted to film, record, or take photographs of council meetings with the chairman's consent. Please liaise with the council scrutiny officer listed in the agenda prior to the start of the meeting so that the chairman can grant permission and those attending the meeting can be made aware of any filming taking place. And for the benefit of everyone here, that's Sally over there. The meeting allows participation by video conference via Microsoft Teams, and some attendees are participating remotely. For those joining us remotely, the chat feature is disabled as its use limits the transparency and open discussion expected in a public meeting. If any member or officer would like to speak during a discussion, they must indicate to the chairman of the committee that they wish to speak by raising their hand. When called by the chairman, speak clearly and directly into the microphone. Members and officers must ensure they have switched off their microphones once they have finished speaking. Use of mobile phones, including for the purpose of recording or filming a meeting, is subject to no interruptions, distractions, or interference being caused to the PA or induction loop systems or any general disturbance to proceedings. The chairman may ask for mobile devices to be switched off in these circumstances. It is requested if you are not using your mobile device for any of the activities outlined above, it be switched off or placed in silent mode during the meeting to prevent interruptions. Apologies for absence. We have received the following apologies: Councillor Tony Virgo and Councillor Ros Chad. And the following councillors will be joining remotely. That's Councillor Carla Mawson and Councillor David Harrison. I'm not sure if David Harrison's actually online at the moment. Okay. Minutes of the previous meeting on the 25th of February 2025. So it's exactly a year to the day since the previous meeting. And for the Select Committee to agree the minutes of the previous meeting on 25th of February 2025 as a true and accurate record of proceedings. Are we agreed? Okay. Okay, declarations of interest. Are there any declarations of disclosable pecuniary or other interests from all members present in respect of any items to be considered at the meeting? And I'll kick that off as I'm a community representative to NHS Frimley ICB.
I'm a member of the patient participation group of the Cambridge practice in Aldershot.
Thank you. Okay. So we move on to public questions. We have received 8 public questions. Please see the questions and written responses provided at the bottom of the document. Written responses have been provided to all public questioners, and we have updated the public questions and written responses to the agenda as a supplementary. So written responses have been circulated to all public questioners ahead of today's meeting. Following any initial reply to a public question, a supplementary question may be asked by the questioner, and the supplementary question must relate to your public question. So are there any public questioners who wish to ask a supplementary question further to their written response? Thank you. If you'd like to come forward and to your left, you'll see the microphone. Yeah, if you just take a seat there, and it should be the button on the right-hand side turns on the microphone, you get a red light.
Will you read out my first question, my initial question? It was about community
I don't
engagement.
actually have a copy in front of me, so.
I don't either.
It's purely the supplementary on the.
Yeah,
the rest
just so that everybody knows which question I'm speaking to, and it was about public engagement, because the last minute referred to continued public cooperation and engagement, and my question said we haven't had any yet.
Okay.
And yeah, what is your our plans for the future? And the written response talked about the consultation on criteria, which were used, and that was pretty much it. And then it talked about an ongoing engagement loop that would be upcoming. So I thank you for the response. Whilst the consultation on criteria could be said to be one incidence of cooperation with the community, it was the only one, whereas the minutes of the last meeting mistakenly implied that there had been several. Even the criteria consultation only received 4,000 replies, which represents just 4% of the population of Surrey Heath alone, and is now far outweighed in numbers by responses to the petition to save the Frimley fuel allotments. Your reply did not address my question in respect of transparency, of which there were no examples up until the written answers to today's questions, which have caused quite a lot of discussion. We have gone straight from being asked about criteria to a preferred site with zero interim engagement and zero information on why this option is preferred over others, when I am certain that the criteria that we co-produced with you did not show that the community or hospital users would be in favour of greenfield development on mature community-owned woodland, of decimation of wildlife habitats, reduced quality of life for many residents, loss of leisure facilities, or longer travel times, which, even if within scope as the crow flies, require journeys along narrow residential roads past multiple schools. The problem with lack of transparency is that no one knows what has been looked at or decided, and there is no trust in the process. I've just seen in your response to another question that further consultation and assessment will only be undertaken once the preferred site has been selected. This is actually frightening to hear. It means there has not and will not be any consultation with the public about the actual sites, and questions are rightly being asked about how we can know the total costs or suitability if the detailed work is only to be done after selection. I've therefore requested 2 supplementary questions. The first about the purpose of the ongoing partnership and cycle of engagement mentioned in your written reply, and the second is about the nature of engagement. So the first question around the purpose of engagement.
I think that's probably enough. It's not really an opportunity to make a speech.
Done it now. I'm on to the questions now.
Yeah, we'll just ask.
That was my response to your written response.
Okay.
Yeah.
We'll just pass the question to Frimley to answer.
So the first question is around the purpose of engagement and whether we actually have any real opportunity to influence the decision away from the Frimley fuel allotments and towards more suitable options, Or when you talk of consultation, is it now only about what colour flowers will be put by the entrance? And I wanted to refer to the letter from Karen Smith, the Minister of State for Secondary Care, to Sean MacDonald of SHBC, that notes that Frimley FPFT will be required to develop a business case for any land that could be purchased. That will require the sign-off by the department with further insurance and scrutiny to ensure that plans are deliverable. Can you give assurance that this business case, that local concerns around the Frimley fuel allotment suitability can still be generally considered and truthfully represented in the formulation of this business case? In particular, whether valuable mature woodland should be in scope when there appear to be a number of other more suitable options nearer major roads, and the shadowy situation around whether the custodians of the Frimley fuel allotments have the right to sell it without consultation.
Thank you, Sue.
First question.
If you could push the button again so the red light goes. Okay, Caroline.
Thank you very much, Chair, and thank you very much for your supplementary question. I think I'd just like to start by saying that there is no decision made on any site, and that we are not here to talk about specific sites because no decision has been made. You're absolutely right. Any decision that is made is subject to a business case that has to be approved by the Department of Health. So I'd like to start by saying that, and I think I'll probably pass over to, on the comms and engagement question, if that's okay, to Kirk.
Yes, thank you, Caroline. Thank you, Sue.
Kirk, if you'd like to introduce yourself.
Oh, sorry, of course, Chairman. Hi, my name's Kirk Ward. I'm Director of Communications and Engagement at Frimley Health. I'm new to the organisation, but not to the NHS. This is the first time I'm here to speak, but it won't be the last, obviously, because this is a really important set of decisions and programme to deliver for the local community. I recognise a lot of what you said in your statement and the supplementary question, and I do recognise the strength of feeling in the local community. I'd start by saying that we are absolutely committed to engaging with patients, public, staff, elected representatives of all kinds throughout the life of this hospital build, not just around specific milestones like site announcements or other things like that. What we have shared with the committee in the papers and what we reference in the presentation as our framework for engagement is in draft form, because we want to co-design that with councillors and with our partners to make sure that we're getting this right. The fear that you expressed about not being able to input into the process, I hear what you're saying, and we want people, local people, users of the services, to engage with us throughout the life of the process. It's not a big bang announcement and then that's the last you'll hear. Any site announcement, when it's made, will be immediately followed by a proactive, detailed and targeted series of engagements across all parts of the communities that we serve. But that won't be the end either. This is an ongoing conversation that we will have over a number of years as the hospital is built. And we're not going to be announcing a preferred site and then holding a referendum on whether people agree with that. What we want is to understand the impacts of the decisions that are being taken in the design of the hospital and the services it provides, and indeed the wider transformation of health and care across our system, because the hospital is a really important part of making sure that health services reflect the needs of the communities that we serve. So yes, that will be part of the conversation, but there is an awful lot for us to engage with communities on over the coming years. But I hear what you're saying, and I do take it on board. So thank you. Thank you, Chair.
That pretty much addressed most of my second question, but can I just add a little tiny extra bit to that? I will be very brief. There's no speech with this one. It was basically about what you referred to as an engagement cycle in the written response. What will that actually look like? Will it include interface with residents' organisations rather than just individuals? And will it actually be a cycle where you feed back to us, or is it just all us?
Thank you. That's a really good point, and I think it speaks to building and maintaining trust through this process. We're committing, and have done in the earlier stages of engagement, to collating a clear summary of what has been shared with us and our responses. We're calling them "you said, we did" reports or documents, and we will continue to. We stand by that approach. We think it's important that the people that we are seen to be hearing what people are telling us and explaining our decisions as we go through the process. So, in short, the short answer to your question is yes, we will be providing feedback as we go along, and that's why we call it an engagement cycle, because it feeds back into the design and continues through the life of the programme.
Thank you very much. So soon we'll be hearing how to actually input to that cycle, will we?
To input into the yes, of course, yeah.
Yes. How will we hear that?
Yes, we've provided the draft document in papers to this committee, and are inviting feedback on the proposed cycle.
Thank you very much.
And I'll confirm that document's actually been published with the agenda. I have a supplementary question, which I've been asked to raise by a resident who can't be here because of work commitments. So the question is from Mr. Matt Everard. It's public question number 2, and his supplementary question is: according to Frimley Health's documents for site selection criteria, transport and access are weighted at 14%. The third highest criterion in the site selection process. Can you clarify what specific transport modelling is being undertaken before the preferred site is selected? And for example, are current comparative journey times being analysed across deprivation groups and public transport accessibility assessed in detail? If detailed transport analysis is only being proposed to be undertaken through the planning process, how can the 14% weighting be robustly and effectively scored at this point?
Thank you, Chair. I'll answer that. Alex White, Programme Director at Frimley Health NHS Foundation Trust. During the site selection process, we have undertaken desktop studies and desktop analysis covering all of the points raised. We have also engaged with the relevant County Council Highways Department and written and obtained reports on the highways analysis, covering all of those aspects. As we move into the next stage, we will undertake detailed modelling using the appropriate software following site surveys.
Thank you for that very full response. Okay, we have no further supplementary questions, I believe, and we have no member questions submitted in advance. So we now move to item 1, sorry, Frimley Health NHS Foundation Trust and Frimley Health and Care System update.
Thank you. I think that's me. Good afternoon, everybody. Good afternoon, Chair, Vice Chair, and members of the committee. Can I just say how happy we are to be here back with you?
Sorry, Sam, can you just introduce yourself?
I was just coming to that. For those who haven't met me, I'm Sam Burrows. I'm the Managing Director of NHS Frimley Integrated Care Board. I think we'd start just by acknowledging the fact there's an increased level of public interest today compared to our previous meetings. We really welcome that, and we look forward to the session that we do have today. We'd recognise that this is a major development for our local health and care system, but also for all of our local residents as well, and the importance of us getting the decisions that lie ahead of us right. And we're looking forward to working with you to do so. We'd also acknowledge there are some anxieties in the local community around things which have been put into the public domain, and we see today as a really good opportunity to address some of these. I would like to confirm what Caroline has already stated, which is that today we will not be announcing a preferred site. That will follow in due course, but today we do want to share updates on the programme overall. So we will be sharing with you today an update on changes happening to NHS commissioning arrangements, changes to integrated care boards and why this matters for the new hospital programme, and also some updates on the transformation work that lies ahead for health services. We'll hear an update on the new hospital programme for Frimley Park, which will be a combination of the national programme, the current local programme status, public engagement plans, and then an overview of the site selection process, assurance, next steps and timeline. And we'll have some more further detail on our plans and how we're going to engage with local communities. We want to create a real culture of engagement, as Kirk has just set out, with some further information on our plans for co-design and co-production and the involvement period that lies ahead. So we've got a lot to cover with you today. So moving on to the next slide, please. A quick update on changes which you may be aware of, which are happening very rapidly now to commissioning arrangements across the country. There is a differential pace to how these changes are being implemented. Some parts of the country are seeing technical legal changes happening more quickly than others. In this part of the world, they are happening very quickly, and these will take effect from the 1st of April this year. The organisation which myself and Ellie here currently work for, NHS Frimley Integrated Care Board, will be dissolved on the 31st of March and will be replaced by a set of new organisations which will pick up parts of the current geography. And just to be really clear with the committee so that it's well understood, there are 3 distinct parts of the current NHS Frimley ICB geography which will be moving. Firstly, we have around 500,000 people who live in the East Berkshire geography of our current footprint. That stretches from Bracknell through to the Royal Borough of Windsor and Maidenhead and across into Slough. These 3 areas in East Berkshire will form a part of a new ICB, which will be known as the Thames Valley ICB, and will be established on the 1st of April 2026. The Thames Valley ICB will cover a population of around 2.5 million people and will also include the populations of the west of Berkshire, as well as Buckinghamshire and Oxfordshire as well. The current residents who live in the North East Hampshire part of the Frimley ICB boundary will be transferring to the Hampshire and Isle of Wight ICB, which clearly is going to expand on the 1st of April to cover these populations. And the residents who are currently covered in the Farnham, Surrey Heath and Ash parts of the Frimley ICB geography will now be covered from a new Surrey and Sussex ICB, which will also be established on the 1st of April 2026. Just to be really clear with you, these are structural changes to the commissioning sector, organisations which are responsible for the allocation of funding and planning decisions for NHS services. These are not withdrawals or changes to current service arrangements on the provider side of the NHS, and I want to reassure you as committee members of that particular fact. There will be some benefits from these changes, greater alignment across our geographies for our populations, a continued focus on the integration of services, a greater focus on prevention and neighbourhood care, and clearly with these new boundaries, greater coterminosity with local authority areas to ensure that we can work more effectively together between health and local authority organisations. Of course, even with all of these changes taking place, and I would like to take the opportunity to recognise these are having a really significant impact on our staff right now. Despite this, we will continue to work extremely collaboratively with our partners in Frimley Health Foundation Trust and also with our partners in Hampshire, Isle of Wight and Surrey and Sussex ICB as well. We will be absolutely ensuring that the corporate knowledge and memory that's been accrued over the last few years of the work that we've done together and collectively on the new hospital programme will be protected. And certainly from Ellie and I, we continue to be look forward working with our colleagues in FHFT and with members of this committee for some time to come into the future as well. So to be really clear on why this matters for the new hospital programme and the development of the new hospital for Frimley Park, there are three key areas here, I think, to acknowledge. The first is that we still need to get the estate right. We know that the current Frimley Park estate limits our resilience, it limits our flexibility, and it does constrain our ability to offer services to all residents in the right place at the right time. Our job in the commissioning sector is to ensure we can drive and fund improvements in this space, and addressing the current estate challenges at Frimley Park clearly is a part of that. The changes to our commissioning boundaries for the ICBs, it doesn't weaken the case for the new hospital. If anything, it strengthens the need for us to have a really resilient anchor provider in this part of the world, particularly where we will have multiple commissioning organisations who are funding and planning services for local people. And then finally, the need to drive and plan for significant transformation and innovation of the service model. And I know that committee members will be extremely familiar with the 10-year health plan that was published last summer. But that really relentless focus on moving more care into the community, doing more care in neighbourhoods, driving more innovation in the use of our digital care models, and really taking a much more preventative approach to how services are delivered, are a core part of how we are going to plan and deliver healthcare services for the decades that still lie ahead of us. It's really important, I think, for the committee to understand that the success of the new hospital programme for Frimley Park is absolutely dependent on the things that we do outside of the hospital as much as it is on the design decisions we take for the inside of the hospital. And we're really looking forward to working with you around the new service models that we will be providing to actually underpin some of this. These programmes, whether it's the commissioning reform or the new hospital programme, are not separate agendas at all. They're entirely mutually reinforcing. I'm now going to hand over to Lars, who's going to pick up the next slide in the presentation. Thank you.
Thanks very much, Sam. So I just want to spend a few minutes just picking up and updating the committee on what Sam has just been taking us through. So I think we're at a very exciting time in the NHS generally for its future, and for all of us, either as current or potential future users of NHS services. The government's 10-year plan, which was published in July last year, 2025, is based around those three key strategic shifts at the top, which will require genuine transformational change in how care is delivered and how we experience care. The 10-year plan also has a really large focus around technology, empowerment, access, and support for healthcare professionals. And for us to be able to deliver it, we are going to require complete whole system change, as Sam was just outlining there, across primary care, secondary care, community services and mental health services as well. Locally, within the trust, within Frimley Health, in that second box there, we have a new clear strategy that is aligned to the 10-year plan that we have called FHFT 2030. Effectively, that is us attempting to deliver the 10-year plan within 5 years by 2030. And we have underpinned that with a range of other strategies, including a clinical, a digital, people, and an estate strategy to help us guide the direction of travel and provide the much needed plan so that we can achieve the huge change that is going to be required. We know that we need to rebuild Frimley Park because of RAC, reinforced aerated autoclaved concrete, but the need to rebuild the hospital gives us an absolutely fantastic opportunity to use this as a catalyst to support the change that is going to be required for us to deliver the care very, very differently. And as Sam mentioned, both the rebuild and the changes to the care delivery absolutely 100% can reinforce each other. The new hospital is obviously going to be a new building, but the new hospital programme is actually about how we deliver the care very, very differently. How do we shape our services differently with others? And how do we make sure that we can meet the future needs of our populations? The diagram there in the green circle is an attempt to show that we're not planning to just replicate what happens currently in the current Frimley Park Hospital in the new hospital, and that we're planning to deliver care very differently across all of our sites, across all of our services, and importantly across other community sites and assets and other sites that actually don't even exist at the moment in terms of healthcare facilities. The transformation of the care is going to include more operating theatre capacity at Heatherwood Hospital in Ascot, more investment in non-clinical services at Wexham Park Hospital in Slough, the use of the non-RAC parts of the current site for the majority of our high volume activity. So by that I mean our outpatient activity and diagnostic activity, which account for well over 50% of the total traffic that comes onto the site every day. And we're going to be focused, in addition to all of that, in terms of providing care much closer to people's homes rather than on the hospital site. And we're going to do this through the use of community hubs and other NHS facilities so that we're more effectively than we are currently working with colleagues to move activity out of a hospital setting. The creation of community diagnostic centres. So we're just opening one in Slough on Monday so that we can ensure much more timely access to diagnostics, speedier diagnosis and quicker access to the care that is needed for patients. And we are looking at the ability to create a community diagnostic centre in either Aldershot or Farnborough to support the local communities as well. And importantly, the use of digital services. So we've used these a lot to enable virtual care, and we will be building on the success of our remote monitoring services and our virtual consultations as we continue to provide care closer to people's homes. So the models of care in terms of how we're going to provide care in the next 5 to 10 years are going to be very, very different to how we provide care currently. And our preferred way forward that we've developed through our strategic outline case for the new hospital 100% supports this transformation as well. We've done a lot of thinking on this, put a lot of energy and effort into it, and we will continue to develop it further at pace in more detail as we move from the strategic outline case into our outline business case for the new hospital, and as we move into the detailed work around what's called the target operating model. So from my perspective, a very, very exciting time ahead. We've got a lot of change coming in terms of how we are going to support working with other members of health and care services to change and develop and re-engineer access to healthcare services and the pace with which we do this. Being able to dovetail that with the opportunity to also rebuild Frimley Park Hospital and create a state-of-the-art facility for those that need hospital services is a really genuinely fantastic opportunity for all of us and for the whole of the local population, both now and obviously into the future.
Thank you, Sam and Lance. I'm going to kick the questions off with one which I think is probably for Sam, which is around the ICB restructure. One of the points that we are very aware of is the very large headcount reduction that's involved. So there is the obvious need for continuity, that we need to actually understand how things are going to be handed over to the new Surrey and Sussex ICB in particular. And also those responsibilities that are moving from the ICBs down to the service providers, and how those are going to be picked up, because all the indications are at the moment that those responsibilities are being passed across but not funded. So how are you going to do the magic bit, please?
Some good questions in there, Trevor. Thank you. So a few things. So firstly, yes, let's just really acknowledge the scale of the headcount reduction that integrated care boards are now going through. And this is obviously a really difficult time for people who currently work in the commissioning sector, certainly for the two organisations which we are most closely working with right now, which is the current Frimley ICB and our colleagues in the current BOB, which is Buckinghamshire, Oxfordshire and Berkshire West ICB. We are looking at headcount reductions which are extremely significant and are very troubling and anxiety causing for people. So we are supporting people through that. I should also say that in terms of being able to describe exactly how the change is going to be made, we started our staff consultation formally yesterday. So we're currently in a period of 45 days of statutory legal consultation with our staff. And it's really important that we don't prejudge the outcome of that consultation process as well. So we will allow that to run its course. But I think the broad principles of your question, Trevor, really do hold, and I will try my best to address those. So firstly, you asked around the transfer of functions to the provider sector. We have identified some services which, as currently delivered as commissioning functions, could be held by provider organisations. Again, that is subject to consultation, so I can't say for certain around how that will currently end out, and I don't want to judge prejudge the consultation process either. However, I can confirm, certainly from a Thames Valley perspective, funding will absolutely follow with the people that deliver those functions as well. So we won't be asking our providers to take the financial risk which may sit with the discharging of those functions. We've also agreed with our colleagues in Hampshire and the Isle of Wight and in the Surrey and Sussex ICB that the Thames Valley ICB will remain as the prime commissioning organisation for Frimley Health Foundation Trust. Now, that's a technical description of the activity, which I accept and understand, but I think it's a really important one, because it means that where we have corporate knowledge and memory and expertise that's been working through Frimley ICB for the last number of years, wherever those people end up, they will continue to be involved with the programme, and we'll be able to protect the knowledge that's been accrued over that time. So we're really conscious of the risk which sits around this, and certainly the pace of change has been significant and a lot faster than previous reorganisations that we've all been involved with. But from my perspective, as we sit today, I think that risk is being really well managed.
Thank you for that response, Sam. I'm going to ask one more, and then I'm going to hopefully get some members put their hands up as well. But the other thing to note is that Healthwatch funding has effectively been removed from the start of the new financial year, and there's a lot of we have a lot of concern about patient voice, to the extent that I put a motion to Surrey County Council to write to the Secretary of State on the issue. Again, the position from the Secretary of State downwards appears to be that the service providers will mark their own homework. So I'm concerned about this one, as I say, that independent voice and the patient's knowledge that they'll be able to complain, and if necessary, it's anonymised, is going away, and there's certainly noticeable concern about that from patients.
Yeah, thank you. So let's be really clear about Healthwatch. We know that it's government policy to abolish Healthwatch as statutory bodies across the country. That includes Healthwatch England and the local health watches that sit underneath it. But I think we should also acknowledge the fact that we have not yet actually seen a health bill. And whilst we are going through a considerable process of change right now, this is not yet backed up by legislation which describes that change. So we await to see what the health bill looks like. And even when the health bill was introduced to Parliament, we don't yet currently know what it will look like when it becomes an act. So being able to say with absolute certainty right now what's going to happen to Healthwatch is a little bit tricky, as it may yet be subject to change through the parliamentary process. I think what we'd all agree on, though, in this panel is the importance of the patient voice and ensuring that there is the ability for patients and more broadly local residents to have their voice heard when it comes to the things which our NHS organisations do in terms of the services that are offered and the experience that our patients receive when they access them. And we're really keen to work with all of our partners in local authorities, participation groups at practice levels and more broadly beyond that to ensure that we do have something which is really robust, which whether we have a health watch or we don't have a health watch in the future, that voice is protected.
Thank you, Sam. Michaela and then Richard.
I know you've been asked this before, Sam. A lot of my residents are really worried about integrated care boards or disappearing, changing and everything. And they're worried about, will they still have access to Frimley Park Foundation Trust? I keep on being asked this. Could you confirm that, please?
So I'm really happy to confirm that there is no change to access planned at all as a result of the changes to integrated care board boundaries.
Yeah,
Thank you, Chair. Are you content that you'll have enough resource left to deliver this programme on time, or will you have to look for some slippage?
Can I just check specifically what you're referring to? Do you mean the new hospital programme? So I think that's a question which is for all of us broadly, rather than just for me as an ICB. Clearly, we're still going through our design process, working out what we want our future structures to look like, how we're going to be organised as an integrated care board, and the people that we have to deliver that. It is going to be a significant headcount reduction. There's no getting away from that. And certainly in the Thames Valley, we'll be covering a geography that's 3 times the size of the current Frimley geography, with around half the number of people. So there is a real challenge to be delivered there. However, to be really clear, this programme around the new hospital is a major priority for us, as you'd expect it to be, given the size of the capital investment and the importance of it to local people, and the underlying challenge that we still have to address with the current Frimley Park site as well. So from my perspective, I'm confident that we've built in sufficient capacity on the commissioning side of our organisation to ensure that work can continue. There are clearly other considerations on the trust and provider side to ensure that they have the resources they need to continue. I won't speak for Lance and colleagues, but you may want to address that directly.
So if I talk about the actual capital programme for delivery of the new hospital, it is, we have a budget, as you'd be aware. We've had a letter from the Secretary of State setting out that budget. Everything that we do is carefully monitored against that budget. So we work in collaboration with the National New Hospital Programme and the Department of Health to ensure that everything we're doing is achievable within the budget. If there are a programme of this scale, as you're alluding to, is, you know, it would be unusual if you didn't get some sort of slippage on scope and budget. And there is a mechanism for managing that back through change control with the national team, should we need it. But let's be clear, there is a budget assigned to all of the projects and programmes within the schemes nationally, and we aim to work within that budget. But as I say, there's a mechanism, should we need it, for managing through change control any deviation or changes, change requests that might be needed along the way.
Very much. Any comment from elsewhere on the officers?
And then just to pick up on the transformation of the services piece, so that very firmly sits in the business as usual for the team, the management teams and the operational teams, the senior nursing and senior medical teams within Frimley Health, working very closely with our partner colleagues in primary care, community services and mental health services. So we have a very clear transformation programme. We have people who are assigned to support that from a programme management perspective, and then it sits squarely in, and we've just undertaken a mini restructure within the organisation. It sits squarely within the remit of very clear roles of senior medical and nursing, allied health professional and operational leaders as well as part of their day jobs.
Thank you. I think that's enough. Thank you, Paul. Thank you.
And Jerry, over to you.
So, sorry, my question's about the community hubs that you were talking about in your presentation. They sound great. My question is, it's quite a simple one really. Where are we expecting to have them? Are there going to be any more in the area? You said there's going to be one in Slough. I think there's one in the Ash Aldershot area. My residents are in the Bratton Forest area. How do we access them? What criteria do you need to access them? Do you have GP referrals, or yeah, how do you access them? But it's more information really for residents, so they know what's coming on and what use they are to them, how they would access them. Just more information out there really to sort of allay fears or bring good news.
So there's a range of different things called, confusingly, a range of different things as well. So the Community Diagnostic Centre, which we're just opening in Slough, well, will open in Slough on Monday, is a brand new build, £25 million worth of capital investment, aimed to deliver around about 150,000 diagnostic tests a year. So a range of plain film, X-ray, ultrasound, MRI scans, CT scans, and then some access to outpatients and some access to blood tests. So that's a completely new build and that's a genuine additional capacity to ensure that we can enable speedier diagnosis. We are also looking at the ability to build a new community diagnostic centre in the south of our patch, around either Aldershot, or it will be in either Aldershot or Farnborough, to ensure appropriate access for the most deprived parts of the community in the south. There's a range of other community hubs that are developing, and Sam will pick up Bracknell in a second. And there's ongoing work and conversations between ourselves from a secondary care provider with our community service providers and our primary care providers as well, about what current estate do we have that could be repurposed and utilised or utilised better, and how would we do that in partnership with each other, so that we're maximising the amount of efficiency, but also really importantly maximising the general location, so that it's as close as possible to people's homes to get easy access and not have to come onto the main hospital site, but also importantly add a genuine additional capacity into the system. And they're community hubs. And then Sam, do you want to pick up around the Bracknell?
Yeah, I'm really happy to. I mean, Bracknell's one of the best news stories we have, I think, in terms of hubs, most excitingly because we've got the Bracknell Health Hub opening pretty much imminently, and part of the redevelopment in the town centre. So best part of £30 million capital investment that we've been building since December 2024. Inside the new building will be maternity services, children and young people services, outpatients, clinics, community services from Berkshire Healthcare Foundation Trust, as well as GP services as well. And having all of those being offered in one physical location in a town centre environment that local people can get to pretty easily, excuse me, is actually, I think, really exciting and a really good development for people in Bracknell. And I would just acknowledge as well, it wouldn't have been possible without really strong partnership working between all of those organisations. And actually, our key partner in the development of that was Bracknell Forest Council, who enabled and facilitated the scheme by holding the investment on our behalf in the NHS. So it's hopefully a great model and a great blueprint which we can demonstrate the value for hubs, because it's about to be open pretty much any week now, and we'll learn from that and use it to refine the offer that we provide across the rest of Frimley geography. But really looking forward to cutting the ribbon on that one.
You okay there, Jerry? I'm going to add one little bit extra to that, because I had a briefing yesterday from South East Coast Ambulance Services and South Central, that they are also in the process of moving to a hub model, which will bring together how they support 111 and 999 with a hub which is staffed with a wide set of skills. So an awful lot of inquiries are going to be fielded very quickly and easily through there, and obviously it provides 24/7 cover effectively. So it's a radical improvement in service that we will be seeing the benefit of in the next year or so. I've got a...
Sam, the transfer of commissioning services is critical, and the timetable for that is very important to the residents. And CAMS is a classic example of Surrey borders being, leaving the northeast area. It would be very helpful to the community and residents to see a programme of transferring of what services are going where and the timetable, so they've got some idea of what is changing at what time in the next 2 years, 18 months, 12 months, because that's the anxiety at the moment with a lot of Hampshire residents, of obviously that use your facility. What's still going to be available whilst the community hubs come into being? Are any of the staff from the ICB, for example, being transferred to those community hubs? Those sort of questions and answers coming out to the public would be very useful.
Yeah, so let me just address a couple of those things, Bill. Thank you. So firstly, just to be really clear and to reiterate what I said in the presentation, we're not anticipating service changes arising as a result of the redrawing of the commissioning boundaries. So the responsibility for the commissioning and the planning of services clearly will shift to different organisations, and certainly for your part of the world in North East Hampshire, that will go to Hampshire and the Isle of Wight's ICB. But you gave a really specific example, which I'm glad you referenced, around children and adolescents mental health services in North East Hampshire, which we've actually only relatively recently seen transfer to Surrey and Borders Partnership Foundation Trust, who have done a really fabulous job, I think, in terms of improving the service offer for that population. I'm not anticipating that service being withdrawn or changed as a result of these boundaries being redrawn. If there was any move to change how that service is provided, that would be a matter for the new ICB clearly, but my anticipation would be they would want to work with you and local people to engage on that change, rather than making that change unilaterally. So it's really important to us as commissioners who are exiting the geography that we do so in a good way, but we're not anticipating services changing as a result of doing so. You did reference ICB staff and where they might be moving to. We do have a small cohort of staff in the current Frimley ICB organisation who have been identified as potentially transferring to either the Hampshire Isle of Wight ICB or to Surrey and Sussex ICB. Again, that is still subject to ongoing staff consultation, so I can't give you any exact numbers or tell you exactly how that's going to play through ultimately, but just for the committee's awareness, we are working with our people to minimise the disruption of that.
Okay, Lance, I have a question which I think is more you than anyone else, because you mentioned Heatherwood and the intention to invest in Heatherwood. Great in the long term. At the moment, we do have a problem in that referral to treatment time overall for the trust is about 57%, according to the national statistics, compared to the NHS objective of 92%, which admittedly no trust is actually getting anywhere near just at the moment. But also orthopaedics is 43%. So it's a major concern that there are people living with major pain for long periods. What is being done to actually deal with the issue that we have at the moment? And appreciate the longer term, and also making sure that we actually really do have the capacity needed going forwards. Because the original Frimley Park Hospital, when it opened, was labelled in the press on the day it opened as being far too small.
Well, on that last note, that's why there's so much work and so much detail going into our demand and capacity analysis at the moment for the new Frimley Park Hospital to make sure that we minimise or mitigate any chance of that the same thing happening with the new facility. So there's a lot going on at the moment. So we are aiming and are confident that we will be at 60% in terms of our referral to treatment times within 18 weeks by the end of this financial year, so i.e. in about 5 weeks' time. And we have committed to getting ourselves to 67% by this time next year in an incremental stage and step up towards the national standards. As you rightly point out, there's nobody or very, very few people in the country achieving the national standard at the moment. There's a whole range of things that we're doing to that. There's some medium-term and planned long-term investment in additional capacity, as I was describing, in terms of additional operating theatres at Heatherwood, for example. There's a lot of work, ongoing work around maximising efficiency and maximising throughput, and making sure that we can safely increase the numbers of procedures that we're undertaking on a daily basis. There's a move to make sure that those procedures are suitable to be undertaken as day cases are undertaken as day cases, and move sort of left in the process, and then those that could be undertaken as complex outpatient procedures are undertaken as such, and therefore undertaken in those types of environments as well. And then we're doing a big piece of work around job planning as well, to make sure that we're maximising the amount of time that all of our senior clinicians are spending doing the activity that adds the most value to our patients. So lots and lots of pieces in there. We've committed to hitting our target, which we negotiated at the start of the year, of 60% at the end of this year, and then 67% for next year as we incrementally move up over the next 3 years.
Thank you for that. There is at least a piece of good news today as well, which is the bone cement crisis appears to have been ameliorated, that NHS supply have done the magic and found alternative sources who are prepared to ramp up and pick things up. And I know that there'll be a lot of people, looking for their deferred appointment to be brought back into play. So thank you for that. Are there any more questions from members? Okay, then I think we can do the new Frimley Park Hospital programme. Thank
you very much, Trevor. So yes, we're going to give an update on the actual programme itself. I mentioned earlier that just to remind people that the new Frimley Park Hospital is part of a national programme, so the National New Hospital Programme. And I thought it would be really helpful for this committee to hear from Paul Mustoe, who is the Joint Senior Responsible Owner for the new hospital programme, sitting within the Department of Health, but I'll let Paul introduce himself in a moment. And just to give some context of the new hospital programme, how we sit within it, and also to hopefully provide some assurance over what we've been doing since we last met and in front of this committee. So I'd like to hand over to Paul. Hello, Paul. See, you're up there, very small on the screen. If you'd like to introduce anybody else who you've got who's joined from your team, that would be really helpful as well. Thank you.
Yes, thanks, Caroline, and thanks, committee, and thanks for allowing me to join remotely. There is myself on the call, Paul Mustoe, and Eleanor, who's in my team as well. So you have two of us here today. So yes, just to introduce myself, I'm the joint SRO, so the senior responsible owner for the new hospital programme, and I'm in DHSC. So the new hospital programme is obviously a large undertaking. There's three principal components, obviously starting with the trust being the key component, which is where the schemes are both sort of commissioned and then delivered from. Then there's NHS England, and that's our programme delivery team, which is in NHS England, and then the sponsor team in DHSC, so providing connection with ministers and wider government. So it's a significant undertaking, as I'm sure you're all aware. There are 46 hospital schemes within the programme, of which there are 29 up and coming, which will go through our main programmatic approach, which I'll give you just a second or two on in a moment. But obviously Frimley forms a key part of that programme. It's one of our 7 RAC hospitals, which are a sort of urgent priority for replacement. So in wave 1 of the new hospital programme. So yeah, a fundamental part of the programme. We've been working very closely with the trust team for quite a long time now. One of the key things that Caroline and team will come on to is the decisions and discussions around site selection, looking at a site for the acute hospital services, as has been mentioned already. So our work has been very much to work alongside the trust to ensure that, or to assure ourselves that the work done around site selection and looking at available sites has been robust, and that it aligns with all the right requirements, which we can confirm it has. It is a complex and challenging piece of work, which I'm sure Caroline and team will speak about in a few moments, and we'll need to go through some significant assurance before any final decisions are made. So I just want to make the point that no decision has been made yet. That will be made through the various business case stages that the scheme will be working its way through. Scheme is currently at the strategic outline case stage, and will then need to move through the outline business case and then the final business case stages to then get onto a construction start and to move ahead. You will all understand, I'm sure, that this is a very large, very complex project, and will have many stages to work through to get to a successful conclusion. But the absolute determination of the programme is that the work is undertaken and is completed, and that it is transformational. The whole ambition of the programme is it transforms not only how new hospitals are planned, designed and built, so very much bringing in Lance's comments around making sure the right services go into these new hospitals and they are the right size, bearing in mind all of the other activity that's happening in the ecosystem that you've heard already, but also that they are transformational in operation as well, in terms of the experiences of staff, of patients, and of all users of the hospitals. So that's the ambition, and obviously the key requirement of the programme is to generate the capacity in the system to do a number of these all at the same time. Just in terms of timing, I thought it was worth mentioning that there has been an update on the RAC analysis work that was carried out back in 2023, which suggested that the RAC hospitals all needed to be replaced by 2030, preferably, to sort of minimise safety concerns for patients and staff using these hospitals. That's been updated and was as an updated report issued towards the end of 2025, which has taken into account the significant mitigation works that's been undertaken in these hospitals since then, and has suggested that those hospitals are safe to operate beyond 2030, as long as that mitigation work continues, they are regularly monitored, and they're managed really effectively. And I'm sure Caroline and Alex can talk more about that as necessary, but that's a key requirement, that they are safe to operate in the short term, as long as they're managed effectively. But obviously that's not changing our ambition, because our ambition is still to replace the hospital with the trust as quickly as is practicable. And we're working to the timescales in the plan for implementation, which was issued at the beginning of 2025. Just a couple of points about the programme before the trust team move into a bit more detail. If you can move on to the next slide, please. Two key bits of the programme which make it, which sort of drive the transformation really. One is standardised designs. So we're developing a standard design called Hospital 2.0 alongside a whole series of clinical input and professional input to drive a standard way of configuring, designing and constructing these new hospitals. And just there's some details there on the slide in terms of how much sort of clinical input there has been to that. And that's the key thing there, is building on best practice, building on the experience of building hospitals in the past, and then putting that all together, all that best practice together into a system that can then be rolled out in a far more efficient and structured way. So here Frimley will be able to draw down all of that expertise, all of those standard designs, and build it into their hospital design going forward, which will drive efficiency and drive the sort of productivity and user gains that I mentioned earlier. The other key thing is we're providing capacity as well in the contracting market. So a key component of the programme is the Hospital 2.0 Alliance, which is our major framework of contractors who will be allocated to each of our key schemes to then partner with trusts to build their new hospitals. And that has been developed over the last year or so and has got right to the stage now. It's in standstill. So we're about to award those contracts to 10 major contractors to then pick up our key schemes in wave one and really drive those forward at pace. So a couple of really key underpinning foundations to the programme as well, which are being put in place to help Frimley and all the other schemes in wave one of the NHP to be driven forward. I'll stop there if that's okay, but I'm very happy to stick around and answer any questions after Caroline, Alex and co have spoken. So thank you.
Thank you very much, Paul. We'll carry on with our update and take some questions at the end, if that's all right with you, Trevor.
Yes, please, Caroline.
Thank you. So next slide is the current programme status. So I'm just going to run through some of the key activities that we've been doing over the last year and where we sort of currently are within the programme. So one of the main things that we needed to do to begin with was to refresh all our strategies, as Lance mentioned earlier, the trust strategy overall, but also to support the trust strategy and delivery of the trust strategy, a clinical strategy, a digital strategy, a people strategy, and an estate strategy, all of which need to form key documentation within our strategic outline case for the new hospital programme. And then building on that, or with those underpinning the work that we do then on demand and capacity modelling. Again, Lance mentioned a significant amount of work that's been going into demand and capacity planning for this phase. It is a really significant amount of work that's been done in collaboration with the national team, who have been playing a part also in challenging us, because they understand, as Paul's mentioned, the transformational ambition within the designs of the new hospital, and then explaining those to us so that we can actually then factor those into our capacity planning and the way that we might manage our demand moving forwards. We've talked also about the shift of care closer to home and out of hospital where it doesn't need to be in a new acute hospital. All of that is part of the demand capacity planning and modelling that we do. We also have the ability to ensure that we can build more capacity should we need it into the future. So to Trevor's point about ensuring we don't build a hospital that's too small on day one, that's factored in as well. That work continues, and in the next phase we do more detailed work, and we'll continue to test the demand and capacity modelling as we go forwards through the whole programme to make sure that nothing changes throughout. We're not going to end up with a hospital that doesn't meet the needs of the population and the demand. So we have completed and submitted the first of 3 formal business cases required within the programme. So there are 3 business cases. There's the strategic outline case, the outline business case, and then a full business case. And supporting those will be other enabling business cases. So for Heatherwood expansion, Heatherwood Hospital expansion, and so on. But the 3 main business cases are those. We've completed the strategic outline case. That's currently with the national team and the Department of Health, and we're working together to make sure that any questions and challenges that they've got and that we've got on those, we're ironing out between us before we move on to formally the next phase. As we've spoken about, the site selection and assurance process is nearing completion. Again, a lot of work being done, detailed work that's happening, and we are coming to a position where we are able to submit a business case, the short form business case, upwards on that. And as Paul said, and as we said earlier, all of that is subject to approval of business cases through to the Department of Health and the NHS England team. Communications and engagement strategy. So the strategy, the newer strategy, the refresh strategy is drafted. It's been brought here for scrutiny to the committee, and it went out with the papers. As we mentioned earlier, we really do want input and feedback from anybody and everybody on that. It's very important we get that right. So we are open to anybody coming forwards with ideas and thoughts about how best to do that in terms of engagement as we go forwards. And that will also go through our internal governance. It's going through our internal governance routes at the moment. So very much an opportunity for people to contribute. As Paul mentioned, so there is a national procurement of building contractors under a framework agreement that is nearing completion, as Paul mentioned, and we very much look forward to being able to meet the builders as and when that's ready and appropriate. In terms of what's underway, in parallel to all of that, we are currently preparing for the second of the 3 formal business cases, so the outline business case. And these are not just documents, but there is process and input, engagement, that's all part of the development of these business cases. So the outline business case is really important because it includes something that Lance mentioned earlier called the target operating model, and the planning for the target operating model. Target operating model provides a vision that sets out where we're going to where we would like services to go as we work up the new clinical models. So to Trevor's point, Bill, it was, who mentioned when will we be able to have something that says where is everything going to go and how does this all come together? The target operating model is the start of trying to of mapping out that vision, and then after that will come a plan for how we're going to implement that vision on an annual basis. And so it's really important that we get input, very wide and broad input from our clinical teams, our system partners into that, so primary care, community care and others, but also that we get patient and public engagement into that at the appropriate time to do so. That's where we'll start to get some co-design work coming in towards the end of the target operating model process, as we start to look at how we're going to implement those models. Are they going to, are they going to work? Are those services going to be in the right position, and how will people access those through the new hubs, as Jerry asked earlier. And then the final bit is team recruitment and appointment of specialist advisors. So we are building, we've got a good team at the moment, a really good, strong team. We're building that even more to ensure that we can continue into the next phases of the programme. And we're also out to procurement for our specialist advisors. So this will be an architect-led design team, so an architect to work with us on how we're going to build up the designs, and also then healthcare planners, cost consultants and quality surveyors and so on, all form part of a very big team of specialist advisors who work with us to ensure we're all working together with the contractors to deliver a really good hospital into the future. So I'm going to pause there for now, hand over to Alex, who's going to take us through a bit of the detail on site selection, and then we'll just finish off with the next steps at the end.
Thank you, Caroline. So I'm just going to talk through a few slides which summarise the process that we're going through to select the site. So if we just rewind a little bit, so May 2023 was when Frimley was officially brought into the new hospital programme. And the immediate piece of work that was undertaken then was to look at the existing site and establish whether through a phased option the existing site could be used. That exercise was concluded that would be not practical and not achievable. So in the latter stages of 2023 and into 2024, an engagement process was undertaken with the local community, which, as mentioned earlier, resulted in 4,000 responses, where the Trust asked what the most important considerations would be around an alternative site for the new hospital. The outcome of that engagement process was independently evaluated and refined to produce key recommendations for the site selection. And then throughout the course of 2024 and ongoing, a long list of sites was drawn up, primarily within a 5-mile radius of the existing site. And then latterly, during the course of the end of 2025, the end of 2024 and into 2025, we re-looked at the existing site again to see if we could do it under a single phase solution. And that concluded that would be incredibly difficult and would take a lot longer and probably cost an awful lot more. Following that analysis, we then went through a period of assurance with the National New Hospital Programme team as well. So if we move on to the next slide, this slide just summarises the dual nature of the work we've been undertaking over the recent 18 months. So really it's around site selection, but also in parallel with that, the production of our strategic outline case, which is, as previously mentioned, the first of our 3 business cases. So this slide shows that while we were evaluating and refining the long list of sites down to a short list of sites, we were also working up the strategic outline case, which is a document prescribed by HMT Green Book. And we have produced, during the production of the strategic outline case, a mandatory minimum of 4 shortlisted options. We've actually got 5 there, because we have to have a BAU, a business as usual option, which is obviously something we can discount fairly quickly. So we've now got 4 options, which we are carrying forward, all 4 we're carrying forward. A do minimum option, which assumes minimal, if any, transformation and no capacity growth. An existing site option, an off-site option with use of retained non-RAC buildings, which was described earlier by Lance, and then a completely off-site option. And as you can see from the slide, we are carrying forward all 4 of those options, but at the moment, our preferred way forward is for what we call the hybrid solution, which is the main acute hospital being off-site, but with reuse of the retained non-RAC buildings. And then in parallel with that, we've gone through the site selection process I've mentioned. And then over the course of the summer, that site selection process was independently assured by the new hospital programme team. And then the short list of options for sites was further evaluated by an independent expert brought in by the new hospital programme team. And all that comes together now. So the strategic outline case is being evaluated at the centre by Paul and Paul's team. And the site selection process is also being evaluated. And the next stage for us is to take forward those 4 options highlighted there into the next of the 3 business cases, the outline business case, and they will be further evaluated. And at the end of that process, which will be around about 18 months hence, we will revert to the terminology preferred option and away from the terminology preferred way forward. And also in parallel with that, we will also get approval to move forward or not with our preferred site. So if we could have the next slide, please. So just to summarise that process, with the existing site was looked at in depth throughout the course of the winter and spring, and we designed an existing site option to quite a high level of detail to really assure ourselves around that as an option. And as I said, we appointed an independent expert in spring to evaluate that, and further evaluation was undertaken and assurance was undertaken during the summer and autumn of this year. The entire site selection process was assured by the NHP over the course of the summer, and then the belt to the braces was an independent analysis of the top 4 shortlisted sites. So that's the process we've been through, and I hope that summarises the next steps, which Caroline will talk through in more detail.
Thank you very much, Alex. And just to round off then, so the next steps and the timeline that we're working to, we've broken it up here for simplicity into short term, medium term and long term. Over the course of the next year, we will be aiming to get the strategic outline case approved. That should be in the not too distant future. It looks like probably back end of the spring that we should get approval for that. That we should then get our land short form outline business case approval. When we have got a land short form outline business case approved, we will be in a position to make an announcement on where the preferred site might be. The target date for that at the moment is June, so summertime this year, but that is obviously subject to ensuring that we get approval on the business cases that we're submitting nationally. We will be then, as soon as that's done, we will be in a position to do further detailed site and transport analysis surveys and all the things that we need to do on transport, public transport and road networks and so on. That all of that is being planned and is getting us to a position of being ready to go on that as and when we can do, because we know that is one of the key questions that's been asked recently as well. In correspondence that's come to us and on social media and so on. And that we will, in parallel, all the time, I think this is a really important point, we continue to monitor all local land opportunities and contingency planning as well. So in parallel to everything, whenever anybody does come up with a suggestion of where a site might be that hasn't been looked at, we do take that and we absolutely do the analysis on that. We don't wait and make sure that we haven't missed anything along the way. We also revisit or have revisited the sites that we've looked at previously to make sure nothing's changed on those and that there isn't an opportunity that's arisen that we have missed along the way somehow. So that's a continuous process. And then we will be putting in planning, consultation and application. Probably early 2027 is the current target timeline for that. Going into the medium term, the planning determination and decision, as I'm sure you will all be aware, could take some length of time, anything up to a year, we believe. And the scheme outline business case will be submitted into the medium term as well. We will then also submit, once we're ready, post-planning, a land short form full business case. And at that point, that will be the point at which we seek approval to buy a piece of land. In the long term, that looks like a full business case being submitted sometime in 28-29, a target build start date of, again, 28-29, and a likely opening date at the moment, subject to everything going smoothly along the way, of 2032-33. And throughout that whole process, we will be doing engagement and involvement, which will increase along the way, particularly around the clinical services discussions that we've talked about earlier. And so I think that's all from me. Open to questions, please, Trevor.
Any questions from members? Sorry. The Mott MacDonald report refers to the increasing problems with Iraq beyond 2030 and the increasing costs. It also says that if there isn't a construction start in the 2027 to 2029 time frame, then effectively alternatives will need to be considered because of the increasing problems that will be encountered. What are we doing to actually make sure that we actually keep to that timeline? Because obviously we've got a pressure that has to be accommodated somehow. So yeah, I'm interested to understand that. The other thing that I would also say for the benefit of the public, which is linked to that, is can we please give specific details as to why the existing site is not suitable? Because that's been raised actually in this room in Surrey Heath Borough Council. And I think we need to actually just, put that one properly to bed by actually going through some of the detail involved.
Thank you, Chair. So I'll come to the last question first. Yes, of course, we can provide detail around the challenges that are presented by the existing site option, and we will liaise outside of this forum to provide that information. With regard to maintaining programme and achieving the milestones, we are working very closely with colleagues at the NHP. We are assured of the NHP's commitment to prioritising the RAC schemes, and that is really encouraging. As Paul said earlier, they are committed to achieving this. The government's policy, the DHSC policy, is to have eliminated all RAC from the NHS estate by 2035. And we've been reassured very recently, in fact, by the NHP, who have redeployed resources to our scheme specifically to ensure that we maintain programme. And we continue to work with the DHSC to streamline processes and monitor our programme and escalate any deviation from what we call anchor milestones along the way. And those milestones have just been described today.
Thank you. Carla Mawson.
Thank you, Chair. I've just got one that moves on from what you've actually just said as well, and then another question. You've got on the slide that Caroline just presented that further detailed site and transport analysis surveys will take place after the site announcement. Now that will, I believe, confuse a lot of our residents, because the thinking from the man on the street, from my perspective, and having talked to a lot of residents about this, is that this should all have been done before the preferred announcement was actually made. Can you go into a bit more detail about what you actually mean by what's on that slide?
Yes, I can take that, Chair. So just to reiterate, high-level site analysis and particularly traffic analysis has been undertaken as part of the evaluation of the sites that we looked at. It's important to note that this is the preferred site. So once we've established the preferred site, that's when we can commit more time and funding to understand that site in a lot more detail. And that will include site surveys and then detailed modelling of those surveys, and including traffic surveys where we go out into the field and spend a good deal of time and money getting under the skin of exactly understanding whether this preferred site and the detailed viability of this preferred site. So that's the sequence of things. It's around ensuring that we use public resource appropriately when we've got certainty around, or more certainty, should I say, around our preferred direction of travel.
Thank you. I mean, just going on from that, I understand what you've just said, but a lot of the people that I've been talking to and seeing comments on social media, etc., won't necessarily understand that. I mean, I understand best value, etc. We've all got to abide by that, but it needs to be made simpler and it needs to be communicated to our residents, your patients, because they will expect when you announce a preferred site that is where the new hospital is going to be. So the slide itself is fine, but it needs more detail and needs communicating in plain, simple English. We all understand it, you understand it, but not everybody will. And that's what concerns me, that the message is not getting out to my residents, Trevor's residents. You know, you talked earlier about areas of less advantage. And yes, we do have a fair number of those. They're not digitally included either. So we need to find ways, or you need to find ways of actually communicating all of this. And so how are you going to do that?
Thank you. There's a lot there. I really value that challenge, actually. And you're absolutely right. We have a responsibility to explain what is happening in a clear and accessible way. That does, and also you're quite astute. It's not just about the language we use when we explain the decisions we take. It's about the methods we use to get the information out to people. And you're right to talk about access to information in terms of digital tools, but it's also true about the different formats we provide information in. And I'm really glad that you're advocating for your constituents in that way. I fully support that, and I'll commit in my role as the Director of Communications for the Trust to striving to make sure that all of our announcements are clear and easily understood. And throughout the course of this programme, that we're providing information in a way that is accessible to all of our communities, whether they're digitally savvy or otherwise. I have the same problem in my own family, so I do accept that. So thank you very much for that challenge.
Okay, well, I would be more than happy to help wherever I can. I've been trying to for a very long time.
I'd love to have a conversation. Thank you.
That would be great. Thank you.
Thank you. Any more from members? Councillor Tier.
Just a comment. I think, Caroline, thank you. I understand far better after today what the programme timeline is going to be. Well, I also hope I understand that spending the public purse on traffic and analyses around several different sites is not a good use of our money. So I get that very much too. But I will go back to the earlier point that communication of that would be very welcome, so that the residents do understand that too. But thank you very much.
Thank you. Okay, we move on to recommendations for this item. I have two suggestions to put for members. One is that we would like the NHS Frimley team to provide the JHOSC with a presentation on the modelling that goes into some detail and takes us through it. It's probably limited interest to the public, but I think we want to be assured on this. It was one of the things that was raised by the Parliamentary Select Committee as well, that they wanted to actually understand the numbers and were concerned about some of the plans in the National Hospital Programme on capacity. And alongside that, I would also say we see a need for monitoring of the transformation programme, that it is actually delivering as expected, and if it's not, reporting of what actions are being taken to correct and bring it back on track, because that's quite vital. Caroline.
Trevor, please, could you just clarify for me the first request. So presentation of the modelling of
Yeah,
capacity. Do you mean the demand and capacity modelling?
Demand and capacity modelling.
Yeah.
That we would want to actually understand that and be assured that it was actually as we expected.
Could I request that we do that in a forum other than this, because it is quite detailed and it will probably
I think
require us being round the table.
that is, I would suggest something to do in a private session to brief
Perfect.
members
Okay.
on the detail of that. But I think that it's important that we actually understand it as a committee.
Thank you.
And obviously then, the transformation, tracking it, reporting it, showing what actions are being taken, to fix things that aren't coming in as expected. It's basically good governance. Is the committee agreed with those recommendations? Okay, we coming up to item 3. I'm going to suggest that we take a short break if we can. Okay.
Sorry, Trevor, could I think Paul may need to disappear possibly.
Yeah.
So if there are no other questions for Paul, could we?
That was my concern.
Yes.
But are there any other questions that we have in relation to the national programme? No, I think we're good.
Okay, thank you
That's
very
great.
much, Eleanor. Thank you.
No problem at all. Thank you very much, all.
Okay, it's just past half past at the moment. If we could be back here at 22 promptly, it would be very helpful. Thank you very much. Okay, thank you everybody. We're now resuming with item 3, the National New Hospital Programme, which I think it's just a case of take us through it.
Thank you, Chair. Yes, hello everybody, Kirk again. I just take a moment to acknowledge the comments and the questions that we've already had. I was just talking to Lance and saying that we've had some really good questions and a really strong steer about the importance of good communications and engagement for this for the success of this programme. The paper that's been submitted and that's available on online as part of the meeting papers is a draft framework, if you like, for how we would like to engage with communities and with partners. I stress that it's a draft, it's not a done deal, and we are really throwing it out there for colleagues and communities and individuals to feed back on that. It also isn't a fixed thing. There isn't one way of engaging a particular community or geography, and there will be a range of different types of communications and engagement methods used in the 12-week focus programme that I mentioned earlier, but also through the lifetime of this project. And I think we've got a sense from earlier presentations just how long-lived this is going to be. And on one of the diagrams, you saw a little arrow at the bottom saying ongoing community engagement and involvement throughout. And it may look like a throwaway or add-on, but I can assure you that it's not. We take this stuff incredibly seriously. And I personally believe, and I think the panel would agree, that getting our communities involved will produce a better outcome. That's the bottom line for us. We want the best possible hospital and services that we can possibly get, and that will be only possible with the involvement of staff, patients, and the public. So it's really important. I won't labour too much on the model because I hope it's clear what we're trying to achieve. I'll just pause by saying I welcome any and all feedback either today or directly to me through my trust email address, and I'm more than happy to have conversations with individuals as well. So I won't linger any further on that slide and hand over to my colleague Ellie. Thank you.
Thanks, Kirk. And Ellie Davis, Associate Director of Communications and Engagement at NHS Frimley ICB. And I think well worth just reiterating the point that the trust team and the ICB team in the communications and engagement space have been working together for a long time now on being really, really clear that this matters, and we advocate for this all the time. And it's been really great to hear engagement mentioned so many times by you all. This matters to us, it matters to you, and we want to get it right. So Kirk has just described a new part of that framework, which is our engagement cycle, and absolutely we'd love to hear your feedback. But we also just wanted to kind of underpin some of the things that we have been working on since we last met you. You have seen already that some of the early engagement, which granted does feel a while ago now, has underpinned the work that we're doing. We make sure that we bring this back and it influences decisions in terms of site selection so far. The other thing that we did last time we were here was we talked through some of the work we've done, and there was real genuine feedback from the committee around who we were hearing from and making sure that we had the broadest range of voices coming to us. We're really keen that that 4,000 number is not the limit of what we're expecting. As we move through this, we'd like to hear from everyone if possible. You know, there is no cap or limit on what we'd like to hear from people. So in the background, we've been doing some detailed work and doing some co-design and co-production with particular groups that were less potentially less heard in the first round. We commissioned a report with our health watches, and there are 3 health watches that are relevant to this patch. They have done a piece of work to help us understand how best to reach people with in seldom heard characteristics. That's been a really exciting piece of work, and it's not been visible to everyone, but there's been a lot of activity in that space. You'll see their broad report at the end of the document that's been published, and I'd really encourage everyone to read it. We've accepted all the recommendations from that report, and they're now embedded into our processes and our ways of working. We've also continued to have several workshops with our stakeholders, community partners, local authorities, MP offices, all to help us understand our communities well and understand how to reach people where they are in spaces that they trust and recognise, and making sure that people do notice this is happening. So to the earlier comment, it's absolutely critical that we get that right, and people have the opportunity to. They may choose not to, but that they have seen it and can if they want to. And everyone in here and other community representatives will be a key part of that. A couple of things to build on for there with key learnings in there is we've heard some things about digital communications today and not relying on that. We've heard from our groups who met through Healthwatch that for some people with seldom heard characteristics, they actually really need digital, and they want us to send things out in WhatsApp so they can translate it on their phones because they don't trust translation that appears elsewhere. Some of our Macular Society and the Deaf Society were saying to us, this is how you can reach us. We want you to do it like that. So we've got some really great feedback and evidence which we can build on and make sure we get this right as we go out with more. We've also been really thinking about how to be culturally aware, and particularly around the translations and the times about when we're going to go out and expect people to come and engage with us, and making sure we're sensitive to that. We've been talking already about going to people where they are. How do we embed in trusted groups and get out there and know what's going on? So if people know events that they think this would be a great space to come and talk to us, for us to hear more from that community, we'd love to hear it. There's also a real strength of feeling in that space that the access and things like parking is vital, but so is what happens in the hospital. And I think that's been really good, reflection from us. We were hearing from young carers groups who were telling us that, they want to feel respected and trusted when they're in the hospital site. And that's really what they wanted to focus on. And they wanted to tell us lots about that, not necessarily about other things that we were asking them. So how can we model that and work through? The other thing we're going to make sure we do is that we connect to things we already know. Everyone doesn't like to be asked the same thing all the time by different organisations. So not only are we connecting across the Trust and the ICB, but we're also reaching out into partners, making sure that we can build on that information. Last year through the ICB, we did a consultation with people, an engagement exercise, on the 3 shifts and the 10-year plan. And we got some really interesting information from that, which we'll be using too. Local people told us what mattered to them. And lots of that was around how they access services, what happens when they're in them, and how they can expect greater standards and greater improvement. So we're really looking forward to sharing these plans with you. And as I said, we'd really like to work with people in this committee to get those right. Kirk.
Thank you, Ellie. Yes, so we talked a little bit earlier about the our intention to announce the preferred site and what would happen after that. And this slide is trying to describe that programme of engagement, but I don't want to send you down a cul-de-sac here, because this 12-week period of focused involvement is really important, and we'll get on the front foot and we want to hear from everybody, but the work to listen to people, to users of services, to staff, to the public, does not stop at that 12-week post-announcement mark. It's the start of a new phase of engagement. So I don't want to mistakenly give the impression that we're just going to do it in a burst and then it will be over. Some things I do want to reflect on for that 12-week period and beyond is that I'm really clear and have experience of working on NHS capital programmes where good engagement genuinely influences the design of what comes to be built and the way services work. And that's super important for things like access, wayfinding, inclusion, dealing with health inequalities, phasing and transition of the changes that are going to happen as a result of the programme. We do need to be clear, though, that no matter the volume of feedback or engagement we undertake, we have no powers to change the funding envelope of the National Hospital Programme or the decision making of the governance structures above us. So there'll be some things that we hear that we sadly have no power to deliver or change, but we will be upfront about what we've heard and what we're doing as a result. And that comes back to the "you said, we did" reports that I mentioned earlier. But I'd just leave it there, really. This is the start of the next phase of engagement. It's not the end of the conversation by any means.
Thank you. Questions from members?
I've got another slide, Trevor. Sorry. I'll finish that off. And then
Please do, Ellie.
Thank you. We just wanted to put this slide in here because we know it really matters what happens with the feedback and information that we get. So I think Trevor mentioned it earlier about the risk around Health Watch in terms of that independence of voice, people marking their own homework. We're really clear that that is not what we want to do. And we have commissioned an independent research partner to help us with this next piece. It's really important that you can all trust that your information, the feedback you give us, comes to us and that it will be looked at with, independent eyes. So that's something we've done as well in the meantime since we were last here, and they're going to help us establish this in a really robust way, an objective way, so that everything that we do feeds into that. They will then be the owners of the report, so we won't be looking at that ourselves, similarly to the way the 23-24 engagement was done. So we just want to give confidence that that's what they will do. Once they have looked at that report, and they'll not just be looking at things like our surveys, they'll be looking at the outreach we do in terms of community events, they'll be looking at sentiment across social media, they'll be looking at potential petitions, they'll be looking at the activity in the community and helping us synthesize that into something we can do with. We will be really clear and do another, you said we did document there, but as Kirk says, the whole point of this is to make improvement, it is to make things better, and it is to make this what the community needs. So it's in our interest to do that well, and we just wanted to give assurance that we'll be doing that in an independent way.
Okay. Questions from members? Councillor Tier.
I'm be very interested to hear what your weight is on the use of social media. We have heard an enormous amount recently from people who think a site has already been chosen or about to be chosen. I would just counsel you, as it were, to have a very, very good, strong strategy for dealing with all the other things that are going to arise, because it's going to be very painful, whichever site is chosen. That's it, really.
Carla.
Thank you, Chair. Yeah, I just want sort of similar to what Councillor Tiers just said. I have said before that I think communication so far has been poor, and that leads to an element of the rumours, and it also leads to this real feeling of a lack of transparency. So my question is, that's fine for the 12-week point and onwards, and I understand it's not just 12 weeks, but that's I mean, if the announcement's made in June, which we all hope it will be, what are you going to do between now and June? Because people are questioning this. They genuinely do believe that a site has been selected, and that needs to be remedied. So how can we go about getting that done?
Caroline.
So if I start and then colleagues can come in. I think, Carla, your points today have been really, really helpful. I think what we need to do between now and then is communicate about the process.
Yeah.
And be really clear what we're aiming to do when we do find a site. It is not the end of the story, it's the start of more work, more analysis, more engagement, and so on. So I don't think people understand that, and I think you've made that quite clear today. And I think that is probably partly what's causing a lot of concern, as you say, because people think that that's already done, and that when we do come out and announce where we would like a site to be, that people might think that's the end of the story, yeah. And it really isn't, because that's the start of doing more analysis, as we've said. Then we go to put planning permission in, and there's a whole planning consultation process which brings in public into that as well. And so there's a whole plan around that I think we have not communicated, and I think is something we should do between now and June to help people understand what that forward plan looks like and what opportunities there are then to input into that. And I think that's a really helpful conversation today to help us shape that. And I think actually working with you to do that, you've offered yourself as somebody who could help us with that. I think it would be very helpful to have some input.
Yep, I can certainly do that. Thanks, Caroline.
That was an excellent answer. I don't think I've got anything to add. But other than I will be in touch so we can have a chat. Thank you.
Perfect.
Thank you. Councillor Withers.
Thank you, Chair. With the Hampshire Together study for a new hospital, when they did the public consultation, they used opinion research services on the feedback consultation, which actually reassured the public at that stage that the consultation that went out and what they did actually got to those areas which the residents wanted it to get to. To date, we haven't talked about using an outside agency to finalise the draft of the public consultation.
So that's what I was referring to as part of that last slide. So bringing in that independent voice, and it might be someone similar to what you've just described, but exactly that, using someone to help us shape it in advance, and making sure that it is robust and independent and gives people confidence that we're doing this in the right way. So yes, we are looking to model that exact approach.
Yeah, I just think it's important you get that out early, so the public know that's happening.
Thank you. And I'll add a little bit more advice in here as well, which is do please make sure that you bring in the organisations that do talk to some of the groups that are perhaps regarded as a little harder to reach. So Surrey Minority Ethnic Forum, Surrey Disabled Coalition, the equivalents in Hampshire and Bracknell Forest. I'm sorry, I don't know them all. Site for Surrey, all of those sorts of people, do please make sure you bring them in. And the second thing that I would say as well, in terms of when you are communicating out, use every vehicle that is available. It is nowhere near enough to just put it on the website somewhere tucked away.
Thank you, Chair.
It's got to be, in your face, no matter which one you use. So Nextdoor is there, as well as Facebook, as well as LinkedIn and anything else that you can think of. Do make sure that you push it by as many channels as you can.
Thank you, Trevor. Just to reassure the committee, all of those organisations that you mentioned there were involved in the Health Watch work, and we've had workshops with those groups. We're really keen to extend that out as we go from co-design into delivery. But yes, we've had some amazing feedback from those groups already, and we'd love more. So again, we'll share those opportunities.
In terms of recommendations, I'm just going to suggest that using an external vendor to make sure that your comms platform is fit for purpose and using the widest possible approach are key to success in this. Welcome the fact that you've involved Health Watch to get their opinion too. But it's a case of you are going to have to shout from the rooftops of exactly what you are doing if you're going to try and convince people that you're following a good, rational path. And that you've got to take what comes back at you and look at it and make full use of it. And hopefully you get 400,000 responses. I think we are down to a date of next meeting. I think we are finished for today. Thank you very much, everybody. Next meeting is to be confirmed.